so to finish up the cancer biology talks, we're going to have Paula Whittingham, who is from the Karmanos Cancer Center at Wayne State University, and she just, as I understand, defended her thesis last December, so it's really Dr. Whittington, as I should introduce her. And the title of her talk is going to be Protection Against Tumors Resistant to HER2 Antibody and Receptor Tyrosine Kinase Inhibitor by HER2 DNA Vaccination. Paula.
Thank you, Dr. Rosenberg. HER2, well, ERBB2 is the gene, HER2 is the human protein, while NU is the rat homolog at about 88%. It is a 185 kilodalton transmembrane protein. It belongs to the family of epidermal growth factor receptors. It has an intracellular tyrosine kinase domain. And what it does, so for example, this is HER2, which is usually in an open conformation. It has, you can't hear me? Okay, it's a little short. It has no known, would that be better? Okay, I'll lean, okay. It has no known ligand, unlike its family members, ERBB1, 3, and 4. So when the ligand binds to one of its family members, they open up and bind with the preferred partner, HER2. And they autophosphorylate and send a proliferation and survival signal intracellularly. HER2, in its association to cancer, is overexpressed on abnormal cancer cells, sometimes 1,000-fold. It's weakly to moderately expressed on normal tissues. And the data shows that HER2 overexpression correlates with a poor prognosis in breast cancer. Okay. For HER2 targeting therapies, there are some that are clinically available. Specifically monoclonal antibodies, recombinant monoclonal antibodies such as trastuzumab, also known as Herceptin, and small tyrosine kinase inhibitors, one that's known as gefitinib or Iressa. Trastuzumab is a standard adjuvant therapy for HER2 FISH-positive breast cancer patients. When it was going through the phase 2 trial, there was 11% response in metastatic breast cancer patients. Unfortunately, the median duration for responses in metastatic patients is about 9 months. And when it was used as a monotherapy, only about 30% of the cancers, 30% of the patients initially responded. So but they've shown better efficacy when they combine it with other chemotherapeutics. Gefitinib, also known as Iressa, is an ATP competitive inhibitor. It also inhibits ERBB1, which is a family member of HER2, and it was approved for treatment of non-small cell lung carcinoma. Unfortunately, it was removed from the market because of other inhibitors that are more effective. Okay, so this animation is just to show you where the targeted therapies might work. Anti-HER2 antibody works on the extracellular portion of the protein. It can cause, there's some theories, they're still not really sure how trastuzumab works per se, but it can cause maybe down modulation of the surface receptor by increasing degradation, targeting, improving targeting for like the innate immune system. And the small tyrosine kinase inhibitor works by blocking phosphorylation of the tyrosine kinase. So that in turn leads to inhibition of your survival pathway or your proliferation pathway. Okay, so what we're saying is that in the clinics you see that you do develop resistance to these monotherapies, even though the breast cancers express HER2 on, you still can't hear me, even though the cancers express HER2 on their surface. And we also saw that not all HER2 positive cancers respond to the targeted therapy initially anyway. So what we're trying to say is that not all HER2 cancers are alike. Just because you express HER2 doesn't mean that you're dependent on it. And when you're looking for therapeutics or novel therapeutics, or when you're studying this in the laboratory, you need to take that into consideration. That just because it expresses HER2, that it's not necessarily going to respond to a targeted therapy. So we need to expand our pool of cells that we use in the laboratory to answer these questions. If they have this resistance, how can we overcome this? Okay, so the cell lines that we assembled are in the biopsy tumor model, biopsy mouse background. D2F2, which was originally a mammary tumor from the biopsy line that we transfected with NU. So D2F2 was originally a tumor that we introduced NU into. And then in the BALB-NUT animal model, these are transgenic mice that develop spontaneous mammary tumors at about 16 weeks of age. So we didn't derive that per se, but tubo was derived from these spontaneous mammary tumors, and all 10 mammary glands developed these tumors. BAM1A, which was also derived from a BALB-NUT spontaneous mammary tumor, was generated by Marie Paichaki in our laboratory. Okay. Then BAM-IR5, whose parental cell line is BAM1A, was cultured in gefitinib, the tyrosine kinase inhibitor, until it acquired a gefitinib resistance up to 5 micromolar. And here, this is a Western blot analysis comparing BAM1A, the parental of BAM-IR5. And we're looking at the phosphorylation of NU after increased exposure to gefitinib. You can see with BAM1A that NU phosphorylation is almost abolished at 10 micromolar concentration of media. And you look at BAM-IR5, even up to 15 micromolar concentration, you don't see a decrease in NU phosphorylation, showing that BAM-IR5, the phosphorylation of NU is no longer, it's less affected by exposure to this tyrosine kinase inhibitor. And this is total NU control. We did find that BAM-IR5 has a mutation, a single point mutation in the ATP binding domain. It's converting a leucine to an isoleucine. So, okay. Next, we wanted to see, this is a flow cytometric analysis. And on the top row, we're looking at new surface expression of the cell lines. The shaded histogram, the shaded is the control, while the outline is the surface NU expression. You can see that tubo expresses surface NU, as well as BAM1A, BAM-IR5, and D2F2 NU. This is a control. This is D2F2 parental cell line, which, because D2F2 didn't have NU until we transfected it. And then K of D is an MHC class 1 molecule in the biopsy background. And you can see that all of these cell lines express MHC class 1. So we know that these cell lines express NU on their surface, so we can target it extracellularly. And then we could possibly target it intracellularly because they express the receptor. And then they also express MHC class 1, meaning that maybe CD8 T cells might be able to help target these cells in vivo. Okay. This is an MTT proliferation analysis, and we're looking at the effect of increasing concentrations of gefitinib and increasing concentrations of anti-NU monoclonal antibody on cell proliferation. And you can see that tubo and BAM1A are definitely more sensitive to the tyrosine kinase inhibitor, while BAM-IR5, which had the acquired resistance, is less sensitive, as well as D2F2 NU, which was transfected. When you look at the effect of anti-NU monoclonal antibody, you also see a similar trend. Tubo, BAM1A are more sensitive, so you see this is time going across the x-axis. And here you can see with the higher concentrations, you see less proliferation. And BAM-IR5, which was derived from BAM1A but has the acquired resistance, appears to be less sensitive to anti-NU monoclonal antibody. And D2F2 NU, again, unaffected. So next we wanted to look at surface modulation. This is flow cytometric analysis again. And you can see that exposure to gefitinib, the shaded is the isotype control, the black is the treatment with gefitinib, and the gray is the black is the treatment with the vehicle control. And the gray is the treatment with either the receptor tyrosine kinase inhibitor, gefitinib, or the anti-NU monoclonal antibody. And you can see with treatments with gefitinib in those sensitive cell lines, except for BAM-IR5, which is less sensitive, you see an increase in surface expression of NU. While with anti-NU monoclonal antibody, you see a down modulation. And this is saying that maybe anti-NU monoclonal antibody is causing either increased degradation of the new surface receptor, and this may be contributing to its effect on inhibition of proliferation, which we showed earlier. Okay. Then we wanted to look at the intracellular signal. So we looked at phospho-AKT, which is downstream of NU. This is Western blot analysis, and with increasing concentrations, 1 is the control, and 4 is the highest concentration. And you can see with TUBO and BAM1A that you get a marked decrease in phospho-AKT expression, while with BAM-IR5, you don't see very much decrease at all. And with D2F2 NU, there's no change. Although it's interesting that it doesn't, well, there might be a slight increase, but you don't see a decrease. Now, we think that might be a blunted signal, and there might be other pathways contributing because it is a transfected cell line. All right, then we're going to go into the animal data. And what we use is a DNA cancer vaccine, which we vaccinate the mice, and 2 weeks after the second vaccination, you look for antibodies specifically to NU. And you can see with the new DNA vaccine, you get specific anti-NU antibodies, and you also get a specific anti-NU T-cell response, which is measured by ELISpot assay. When we go into the animal data and we want to see protection against tumor, you can see that the controls are the triangles, all right, and the squares are mice that were vaccinated and then challenged. And you can see that all cell lines, despite their sensitivities to either antibody or gefitinib, they were all rejected by giving the mice the DNA vaccine prior to tumor inoculation. With TUBO and BAM1A, well, next we also wanted to see whether they were more sensitive to antibody in vivo, or you require the T cells, the presence of the T cells to prevent tumor growth. So we depleted CD4 and CD8 T cells in some groups prior to tumor inoculation. With TUBO and BAM1A, it didn't make a difference. You still rejected tumor growth. But with BAM-IR5 and D2F2 NU, which we saw had less sensitivity in vitro, you can see that you need the presence of your T cells there to inhibit growth 100%, and more so with D2F2 NU. So by exposing BAM1A to gefitinib in culture and acquiring a resistance, you've increased the threshold per se of, you've increased its resistance against antibody in vivo, that's what we're saying. So you need T cells. And we also took these cells and we looked for new surface expression after tumor growth. And you can see with BAM-IR5, it maintains surface NU expression, so it's still dependent on NU, we're thinking. With D2F2 NU, it was a transfected cell line, so it looks like it lost its surface NU expression. Okay, in conclusion, TUBO, BAM1A, IR5, and NU may represent, well, they do represent HER2 positive breast cancers with varying levels of sensitivity to antibody and receptor tyrosine kinase treatment. But however, both sensitive and resistant tumors were controlled by DNA vaccination. Okay, thank you very much. Any questions?
We have time for one very short question.
Okay, thank you.
Well,
Okay. Yes, Dr. Rosenberg.
30 seconds left on my watch. So the anti-tyrosine kinase antibody is acting against an intracellular molecule, whereas the anti-HER2 NU antibody acts via cell surface molecule. So what's the mechanism by which the anti-tyrosine kinase antibody actually mediates its effect, since cells are not permeable to antibodies?
It's not an antibody. I'm sorry, I wasn't very clear. It's a small molecule tyrosine kinase inhibitor. So it can easily pass through the lipid membrane, and it gets in there and it blocks it. It's a competitive inhibitor of ATP. It's an ATP analog, in fact. So thank you.